following presentation is sponsored by the Alabama Department of Mental Health, Lifting Life's Possibilities, and Southern Coast ATTC, unifying science, education, and services to transform lives.
These are the adult levels of care. What I would like to tell you are there are 2 levels of care in your PPC-2R. Does anybody remember what PPC-2R stands for? Patient Placement Criteria, Addition to Revised. Okay. We have the point 5, which is early intervention. This is a new level of care for many people. We have outpatient, which a lot of people are consider what? Generalized outpatient. That's a level 1. Level 2 is intensive outpatient or partial hospitalization. We're looking at level 3, which is residential inpatient treatment. And we are looking at level 4, which is a medically managed intensive inpatient treatment program. Now, ASAM has the 5 specific levels of care, and then we have sub-levels of care also. So these are the exciting things for me, and I hope for you too. So let's take a look at the levels of care individually. The point 5 is the early intervention program. It serves folks who have problems related to substance abuse, and they have no diagnosis. Okay? They have problems or risk factors that could develop into a diagnosis. To this point in time, have you found that a lot of times you will get folks who come in and you really can't get a full diagnosis on them? Sometimes they forget to tell you things. Sometimes they're not as accurate as you would like them to be because they forget things. However, someone says, way above me, they need to be in treatment. So sometimes we have to pull some information out that will give them some sort of a diagnosis, right? Do people agree with that? Because we wanted to help them. But they're not ready for a level 1, which is your outpatient treatment. This level, point 5, says they cannot have a diagnosis. We put folks here that do not have a diagnosis. They have risk factors. We want to address the risk factors. And people are saying, well, I don't understand. What do you mean? Why are we talking about risk factors? Well, we're going to get into that in just a minute. This level of care can be delivered in many different ways, individual or group. You don't have to put someone in a group all the time. The great thing about ASAM is no one says they have to be in a group. You could put them in individual treatment, and they can be considered having treatment. It explores and addresses problems and or risk factors that appear to be related to substance use. Okay? It helps the individual recognize the harmful consequences of their inappropriate or continued use. Shall we digest that just a little? What do you think so far? What do you think about that?
Is it considered educational?
Education, prevention, intervention. Yes?
Can you put someone that has a diagnosis but is in pre-contemplation in this level?
No. No diagnosis whatsoever in this particular level. That's the beauty of it. And we're going to talk about that. Can you think in your mind what point 5 might look like? Who might come in to your agency with a point 5? Adolescents, absolutely. Adolescents. Have you ever had an adolescent that comes in and, we want to put them in treatment, but they don't have a diagnosis? Remember I said earlier, diagnosis does not dictate treatment placement. The point 5 specifically says a person does not have a diagnosis. And we will get into some examples. Now, the duration of this program is their ability to comprehend the information provided. Also, to be able to apply the information to avoid problems in the future, or we transfer them to a higher level of care because a diagnosis has been established. Those folks who come in and we can't get enough information with the diagnosis because they're not giving it to us, we can't come up with the criteria, we can't say they have a substance abuse, we can't say they have substance dependence. Point 5 is the perfect place for them where you can do individual sessions, group sessions, or a combination of the two. And the length of service is not dictated by 8 sessions, 10 sessions, 12 sessions, or 3 sessions. The length of service is determined by the provider. Now, don't forget about risk factors here. Let's take a look at what risk factors would look like in relationship to a 0.5. Can you give me some examples of risk factors? Does anybody have any idea what a risk factor might look like at a 0.5 level?
Peer group.
Pardon?
The peer group.
The peer group, absolutely. You might live with a spouse who is using, correct? But you're not. So we have risk factors that could contribute to putting them into a 0.5. What other kinds of risk factors might there be to justify a 0.5 because we don't have a diagnosis? Pardon? Family history. Have you ever assessed someone who has had 1 DUI? Anybody ever see anybody who has had 1 DUI? Okay? Because they have 1 DUI, do they traditionally have to go into the court system? Yes. So the court system says, we need to get you in for an assessment. Okay? So they come in for the assessment, and you take a good history, and what do you find out? It was an anniversary, person drank too much, and got into their car and drove home. You do an extensive history, and you can't find anything other than this 1 DUI because they drink holidays. Maybe they'll have a drink for a birthday, christening, whatever holiday there might be, and they've had 1 DUI. Do they have some risk factors that we might want to take a look at? But they don't have a diagnosis. Do we want to look at intervention? Do we want to look at prevention? And do we want to look at some education? Does that make sense? So did everyone hear that? Looking at someone who comes into your agency, right? They got a DUI. Their peer group, they drink after work maybe 2 or 3 beers, but that's all they have. But you bring them in because the court is saying there's some risk factors here. We want to take a look at that. Good example. Let's talk about the folks who come out of the prison system for just a minute. Anybody ever have those folks come into your agency? However, they went into the prison system because they were dealing drugs. But what does the court say? In order for early release, you have to go into a treatment program. Do they typically have some risk factors? Absolutely. Some folks, as in my experience, have never really used. They like the experience and the high from selling. Have you ever had folks like that? And where do we put them? IOP, OP, pardon? We put them right in to a treatment program because we have no place else to put them. If they don't have a diagnosis, and sometimes folks don't who just are dealing, right, manufacturing, would this be a good level of care? Could we put them in individual sessions and continually assess, educate, and see if we can reduce their behaviors and their risk factors? Let's do level 1, outpatient treatment. For level 1 outpatient treatment, it's an organized service delivered in a wide variety of settings, and that's the important piece. The other piece is we have regularly scheduled meetings. It follows policy procedures and or medical protocols. The other thing that we're looking at, it's provided by addiction or mental health counselors. And services include evaluation, treatment, and recovery issues. Similar to what you're familiar with outpatient today, right? What I want to point out is it can be given and delivered in a wide variety of settings. Meaning, you could have someone in a level 1 and do individual sessions with them. You're not locked into doing group. You could do these sessions at any time of the day, evening, or on weekends. Remember, the big thing here is we're looking at client-driven, not program-driven. There's nothing in here that says it has to be group therapy. When we look at level 1, it's designed to treat individuals. Level of problem severity. We want to look at their severity. We want to achieve permanent changes and improve mental functioning. We also want to look at programs where they address personal lifestyles, attitudes, and behaviors that can impact or prevent accomplishing the goals of treatment. Level 1 may be the initial phase of treatment, a step-down phase, or you're looking at the individual who is not ready or willing to engage in treatment, or they're at the pre-contemplation phase. So can you see how level 1, because we can do it in many different settings, we could have someone in pre-contemplation where they're not ready to commit to a full recovery program. It's an excellent way to engage the resistant client. Okay? The duration of the services varies depending on the illness and response to treatment. Now, this is the important part of level 1. Level 1 is less than 9 hours per week for adults. It's less than 6 hours per week for adolescents. Typically, your outpatient programs now are what? In the standards, does everybody know you have to do, like, for at least for IOP, 100 hours within 6 months, right? ASAM is giving you an opportunity to say less than 9 hours per week, and the length of service depends on the individual's progress. Any questions about level 1? When we look at level 2, here are some of the generalized components of level 2. It can be conducted during the day, evening, or on weekends. That depends on the agency, that depends on the clinicians. This particular level has the capacity to arrange for medical and psychiatric consultation, psychopharmacology consultation, medical management, and 24-hour crisis service. It does not say that you have to provide them. You have the capacity to arrange for them by using providers or other agencies in your organization or outside of your organization. So you're going to look at affiliations with other levels of care. Also, some programs can provide overnight housing who have problems related to their recovery environment for those individuals, but they don't need 24-hour supervision. That's a level 2, and those are the generalized components. So level 2 is intensive outpatient and also partial hospitalization. In level 2.1, which is your IOP, you are providing 9 or more hours of structured treatment a week for the adult population, or 6 or more hours per week for the adolescents. What's the big difference between IOP and OP? The number of hours. Less than 9 for outpatient, 9 or more for IOP. You have counseling, education related to your substance and mental health disorders. Psychiatric and medical services are addressed through consultation, and you will make referrals for that. IOPs generally do not have the capacity to treat individuals with unstable psychiatric issues. So when we look at the IOP, which is a level 2.1, 9 or more hours per week for the adult, 6 or more for the adolescents. We want to look at counseling and education. Psychiatric and medical services are addressed through consultation, and typically they don't have the capacity to treat the unstable medical or psychiatric issues. Think about it for a minute. If you have someone who's in a level 1 program, all right, and they're coming to group, however, they're just coming to group. You know what I'm talking about here. They're just coming to group. They're occupying the chair. They're not communicating with the rest of the group. Sometimes they're a little resistant, sometimes they're, causing a little trouble, but they're sitting in the chair. All right? What do we want to do with those folks? Do we want to pull them out of group maybe and put them into individual sessions? Because we don't want to jeopardize the integrity of the group. So we have the IOP. The other level of care is called a 2.5, which is partial hospitalization. I don't know if that's a new term for many folks, but partial hospitalization is now offered under the ASAM levels of care. It provides 20 or more hours of services per week. And what you're looking at typically is the direct access to psychiatric and medical and laboratory services when warranted. 20 or more hours per week. Many times what we call now, anybody in here do special women's programming? Yes. Is that typically what your program looks like? How many hours do you run your program per week? No? 9. So you run that for 9. So they come how many hours per day? 3? Okay. So that would still be a 0.21, because that's an IOP. But you also now have another component where you can put at 2.5 and have people in partial hospitalization. We don't need to put them in the hospital. They need more than IOP. Now we have a level of care that can service folks who need that. Does that make sense? When you're looking at any of the level 2 services, and you're going to see this repeated all the time, duration of the services depends on the severity of the individual's illness and their response to treatment. No one is saying to you, you have to keep them for 8 sessions. You have to keep them for 10 sessions. What it's saying is, as the clinician, you have the ability to make that decision based on your client and based on you. Now we're going to take a look at the residential, which is level 3. Level 3, some of the general characteristics of level 3. What we're looking at now is folks typically have what we call functional deficits. When we get to the level 3, they require safe and stable living environments to develop their recovery skills. That's what a level 3 is looking at. Treatment is provided in a 24-hour residential setting and is staffed 24 hours a day. Self-help meetings are usually on site, and living environments can be within the residential program or in separate facilities. The other thing is the living environment and the treatment provider must be close enough so that the treatment plan can be addressed at both sites. Now, what does that mean? Typically, when we look at residential programs, the residential program not only provides the housing, but they provide the outpatient services. What we're saying here for level 3 is that you could have the residential service and you could provide the housing, but you could provide the outpatient services. You just want to make sure that as clinicians you're talking to each other so that the treatment plan stays consistent on both sides. Okay? Does that make sense? Let's take a look at some of the sublevels. Level 3 provides residential service from the least clinically managed to the most intense medically monitored. And this is where we'll talk about the definition of terms right now before we get into anything else. When we look at clinically managed, we're looking at it's directed by a non-physician addiction specialist rather than medical personnel. Now these are a little different in terms because typically we look at residential as having what? Somebody medical on staff. These are actually clinically managed. This staff is appropriate for individuals whose primary problems include emotional, behavioral, and cognitive issues, including readiness to change, relapse, or recovery environment issues. Problems in Dimension 1 and Dimension 2, if there are any, are very, very minimal. That's what we need to remember when we're looking at clinically managed. We don't have a significant issue in Dimension 1 or Dimension 2. So these levels would call 3, 4, 5, and 6. Medically monitored, you have an interdisciplinary team of nurses, counselors, social workers, addiction specialists, technical personnel, under the direct supervision of a licensed physician. This program is supervised by a licensed physician. This is medically monitored. These apply to Dimensions 1 and 2. We want a physician to be taking a look at folks who are under Dimension 1, which is your intoxication, and Dimension 2, which is your biomedical. When we get into medically managed, we're looking at daily medical care where we need diagnostic and treatment services that are directly provided or managed by an appropriately trained and licensed physician. Again, we're looking at Dimensions 1 and 2. And Kathy is going to hand out the definition of terms for you so that they're somewhat bigger than they are in your PowerPoint. Because as we go through the rest of Level 3, we will be looking specifically at whether they're clinically managed, medically monitored, or medically managed. Up until this point, we've done the general characteristics of residential programming under Level 3. Now we're going to begin to break them out. Level 3.1 is your clinically managed, low-intensity residential services. That's a lot of words. Now, these programs offer a minimum of 5 hours per week. Now, stay with me here for a minute because we're talking about 3.1. Minimum of 5 hours per week. That doesn't say that's the maximum, that's the minimum at a 3.1. We're looking at focusing on recovery skills, preventing relapse, improving emotional functioning, and working towards integration into society again. And self-help meetings are typically provided on site. When we look at 3.1, we're looking at component parts, and these are some of the things that are included. If you have a residential program, 3.1, clinically managed, low intensity, you're looking at these types of substance abuse programming. So you can either provide a Level 1 or you can provide a Level 2.1. You have a very structured environment. It's staffed 24 hours a day. And living skills are promoted through community and housing meetings. When we look at functional deficits in this particular populations, folks have a problem with applying recovery skills, lack of personal responsibility. They also have a lack of connection to the worlds of work, education, and family. So we're looking at functional deficits here. Now, can you see why? I'm going to give you an example here for just a minute and tell me what you think. We could have a person who has an alcohol dependence diagnosis, okay? They could also be in some cases, in the maintenance stage of readiness to change. We could justify putting them into a low-intensity 3.1 residential service if we are looking at functional deficits that impact their ability to remain sober. Typically, what we do is we put people in who are currently using and can't stay clean and sober, and that's when we look at residential. Within ASAM, we have more options. They don't have to be an active addiction in order, in some cases, to fall under some of these residential service programs. It can also meet the needs of the individual who has not yet acknowledged that they have a substance use related problem. It's low intensity and it's clinically managed. We're looking at discovery rather than recovery issues. When we place someone in this level of care without the acknowledgement of substance use issues, it would be justified if their living environment was too toxic for them to remain sober. So the question is, or the concern would be, you have someone who is not yet acknowledged they have a problem, but you also have a population of folks who have acknowledged they have a problem. So let's go back and think about when we looked at outpatient or intensive outpatient, and we were talking about the person whose readiness for change. They had different levels of readiness for change or stages of change. Would we put them together? Sure, we do that all the time, don't we? Because sometimes, as you were saying, right, when we look at that, they can benefit and help the person who has not come along yet. This does the same thing. Because what we're looking at is discovery rather than recovery issues, and we're looking at their type of environment that they currently live in. It's not intended to be sober houses, boarding houses, or treatments where treatment services are not provided. So these are not services where treatment is not provided. The question is discovery versus recovery issues. Okay? Help me out and let's explain this together so that we're all on the same page. How would we look at discovery? Recognition of a problem. I'm sorry?
Maybe recognition of a problem over time.
Recognition of looking at a problem over time.
How the problem impacts the person in different areas of their life.
How the problem has affected different areas of their life. What other?
Self-assessment.
Self-assessment. Those would be some of the discovery type issues that we're going to look at, right? We're going to look at some of that. I think someone mentioned before when we were talking about some motivational interviewing styles is to point out how some of the things that have happened in a person's life have caused where they are today, because they might not understand that. When we look at recovery, what are we looking at? We're looking at providing recovery. Now, a lot of people come into treatment in the recovery phase of treatment. Now remember, this is a new concept now, so we have different options on how we treat people. Everyone does not have to be at the same place. Look at the third paragraph here. Placement of an individual in this particular level of care, 3.1, would be justified even though they didn't acknowledge that they had a substance abuse problem, and if they had a living environment that was toxic to any type of recovery. We're looking at a lot of different things when we place somebody in residential now. We're looking at functional deficits, as I said before, and we're looking at another piece. When they have an environment that is toxic to their recovery environment. Typically, when we put somebody in a residential program now, they have to be in full-blown addiction, don't they? The beauty of ASAM is that we don't have to be that narrow-minded anymore. We don't have to be that narrow-minded. we need to look at all of the dimensions, 1 through 6. We have more options now for placement than we did before. I know that can be a concept that can be challenging and also difficult because we're used to doing it the old-fashioned way, which is you meet certain criteria based on your diagnosis and how you are using in order to go into a residential program. So how do we make a residential referral for someone who has been tested clean? All right. What you're going to be looking for is, let me back up for 1 second. On the new assessment tool, okay, we're going to be looking at every single one of the 6 dimensions. Tomorrow we're going to be looking at risk rating, so keep that in mind. What we're going to look at is where are they on the risk rating scale. If someone's risk rating is higher, let's say in dimension 5 and 6, we would be looking at the possibility of residential services rather than an IOP. So if you can hold on to that, because it's a little confusing, but what we're going to be looking at are risk ratings, functional deficits, and all 6 of the dimensions rather than just one, which is are they using or are they not using. So what I'd like you to do right now is to think outside the box. Take the information that is being presented on these residential programs and understand that they have a place in the communities. Look at your definition of terms. Have a clearer understanding of when we talk clinically managed versus medically monitored or managed. Big difference on what the requirements are when we're looking at residential. In this particular case, residential goes from the least intensive to the most intensive. So you can have someone in the least intensive going to the most intensive. You can also have that, you don't have to have just one in your, if you have residential, you can have multiple levels of that. You don't have to be locked into just one, because each one of these levels, 3.1, 3.5, 3.1, 3.3, 3.5, 3.7, are all residential programs from the least intensive to the most intensive. And you can be certified for those levels individually. You are not going to be just certified for level 3. You're going to be certified for the services that you provide. Does that make sense? So you're not just locked into level 3. You can choose 1, 3, 5, or 7. Based on your staff, based on your facilities, based on what you can provide. Does that help at all? And we said it's not intended to include sober houses, boarding houses, or group homes where we don't provide treatments, services. We want to make sure that treatment services are being provided. If someone has a sober house, if someone has a boarding house, or if someone has a group home, treatment services must be provided if they want to be considered a residential program. Let's see if we can take a look at 3.3. We're still looking at clinically managed, and if you need to, take a look at your cheat sheet that talks about clinically managed. This level of care is frequently referred to, as you can see here, as extended or long-term care. As in the level 3.1, programs are provided in a structured environment in combination with medium-intensity clinical services, and we'll talk about that. So here are the differences from 3.1. What we're looking at, the substance use has significantly impaired the individual's life to the extent that outpatient treatment or outpatient motivation or relapse prevention strategies are ineffective. We're increasing the level of care now. Functional deficits in this particular level are cognitive and are either temporary or in some cases permanent. We're talking about functional deficits again. Temporary deficits can be the result of substance use, which is like, organic brain syndrome. How many times have you seen that a psychiatrist will write substance-induced mood disorder, substance-induced psychosis, substance-induced something? And those would be temporary deficits as the result of substance use, correct? And typically, if they are substance-induced, they are going to clear as the substance is removed from the equation. Treatment needs to be slower, more repetitive, and more concrete in nature. So what we're looking here, when we're looking at functional deficits, slower, more repetitive, and more concrete in nature. As the impairment clears up, treatment can be provided at a lower level of care. Okay? So what we're looking here is the difference between 3 and 1. These are the differences. If we want to remain in level 3.3, if we want to retain someone there, we're looking at chronic brain syndrome, older adults with cognitive deficits, okay? Individuals with traumatic brain injury or individuals with mental retardation. Also, these impairments, when we look at this, the individuals with these impairments, outpatient treatment would not be clinically appropriate. Our functional deficits are at a place where outpatient treatment is not going to be appropriate because we want to be more repetitive, we want to be slower, and more concrete in nature. What we want to look at is doing some reintegration of the individual into the community, requiring some ongoing case management, looking at housing, vocational needs, transportation, and continued self-help involvement. So from 3.1 to 3.3, it's still clinically managed, but we're increasing the intensity of the services. Someone could come in a 3.3 and be put into a 3.1 as their cognitive issues become less or improve. Okay? Pretty clear on 3.3. Some subtle differences. 3.5 is the high intensity services, but it's still clinically managed. We haven't changed the level of professional intervention. In a 3.5, people present with multiple issues: substance abuse, criminal activity, psychological problems, impaired functioning, and difficulty in conforming to mainstream values. DSM-X's 1 mental health disorders are of a serious nature. We're looking at things like schizophrenia, bipolar, and major depression. Also, you might see the person coming into this level of care at 3.5 with borderline, narcissistic, and antisocial personality disorders and or traits. If we want to place someone in level 3.5, we're looking at someone who presents with chaotic, non-supportive, and abusive interpersonal relationships. There is also a long history of treatment attempts or criminal justice histories and limited work or educational experiences. More antisocial values are present. We've gone from 3.1 to 3.3 to 3.5. Can we see where the deficits have gone up in nature? The needs have gone up in nature. We're not just talking about their use right now. We're talking about more of the cognitive behavioral issues. We're talking more about functional deficits. Now, the length of stay is based on the individual's progress, but tends to be longer and more intense, and we can see why that would be. Treatment is typically habilitative rather than rehabilitative, especially when we're looking at antisocial traits. And some treatment programs offer this level with full medical services attached to it. Thoughts or comments about this particular 3.5 level of care? We were talking about beds and waiting lists a little while ago. Can you see how we can free up some beds if we don't have to keep people for 28 days or 15 days or 45 days? As things begin to improve, as the circumstances begin to improve, can we move them down, which frees up a bed? When we look at the 3.7, and we're looking now at medically monitored, it provides 24-hour professionally directed evaluation, observation, medical monitoring, and addiction treatment. It's not a hospital setting or a medically managed program. It's medically monitored, and go back to your definition. Anyone requiring a 3.7 present with functional deficits such as withdrawal risk, medical problems, emotional issues that can impair their ability to engage in treatment. For the 3.7, it varies, but it tends to be significantly longer than any other level 3 program. So we've looked at all of the levels of care under the residential portion of the levels of care. 1, 3, 5, 7. 1, 3, and 5 are what? Clinically managed. And then we get to 7, which is medically monitored. The level 4 is the medically managed intensive inpatient treatment. When we look at services under this level of care, you're looking at 24 hours a day in a permanent facility with inpatient beds. You have the full resources of an acute general care or psychiatric hospital, and they provide both substance abuse services and the treatment of any co-occurring biomedical conditions and also mental health issues. So when someone goes into a level 4, you're looking at substance abuse, possibly medical conditions, and mental health issues. We also look at the length of stay varying, obviously with the severity of the person's illness. But the focus is stabilization and preparation to move to a lower level of care. The focus is preparation and stabilization, freeing up those beds. The adult admission crosswalk. The crosswalk contains the dimensions, the 6 dimensions, and then you have the levels of care across the top. And it tells you about each level of care and the intensity and the staffing. But as you can see from this, and as I told you, as we get into the risk rating, someone who has a higher risk rating in dimension 1 or 2 are going to qualify or be placed in the higher level of care, either a 3.7 or a 4. So what we're looking at is this is just a crosswalk, and it's a snapshot of all of the levels of care and all of the dimensions. You can use the other handout that you had before when we looked at one of the first handouts that talked about the dimensions and some of the questions that you would ask or some of the things that you would look at, and be able to use these two pieces of paper together and very quickly do a level of care if you didn't have a risk rating. Let's talk about opiate maintenance therapy, because it is part of the ASAM criteria. One of the things to think about when we talk about opiate maintenance therapy is the fact that it's not considered a level of care, but rather a separate service that can be incorporated into any of the levels of care 1 through what? 4. It couldn't be incorporated into a 0.5. Why?
You'd have to have a diagnosis of opioid dependency.
Yeah, you'd have to have a diagnosis. Okay. The length of service also varies depending on the person's response to treatment and whether they want to continue the opiate maintenance or they don't. Now, in this particular revised edition, the second one, Suboxone wasn't included in that because at the time they didn't have enough information. However, I see that in the next revision that Suboxone will be a part of this, and we will talk about opiate maintenance and Suboxone together. Let's talk about how we could incorporate opiate maintenance therapy into any of the levels of care. As an example, I had someone who was in a special women's program, and they had also had an opiate addiction issue, and they were receiving opiate maintenance therapy and still participating in the special women's program, which was an intensive outpatient program. I had another client who was had a co-occurring disorder, and they were going to what we considered like a day treatment program, who was also participating in the opiate maintenance therapy service level. So we could have this huge full discussion about methadone maintenance, abstinence-based programs. How do they come together? Do they come together? Should they come together? Should we include Suboxone? What I want you to see, though, is that the authors of the ASAM placement criteria said we recognize opiate maintenance therapy as a legitimate service that can be provided in any of the levels of care. Now, we won't have a huge discussion, but I want to say this to you. Do you remember, does anyone in here remember the day if you were taking antidepressant medications where you were not allowed into treatment? If you were taking antipsychotic medications, you were not allowed into my treatment program. You could go over there to their treatment program, but not my treatment program. Some are still there. So when we think about ourselves as clinicians, we need to really open our minds to options for our clients, because this is client-driven, not program-driven. Now, everybody has their rules, but I wanted to throw that out there for you, because as we continue to move forward in this field and adopt some of the ASAM placement criteria, we need to know that the physicians who authored this particular manual recognized opiate maintenance therapy as a legitimate service. So I just wanted to make that, just put that out there for you to understand that as clinicians, we need to look at the whole person, not just a piece of the person, because we don't all, have to go to the same grocery store to get our groceries. We can do it differently. Two things to remember. Opiate maintenance is part of ASAM, and it's a viable part of ASAM, or they would not have put it in there. So obviously the doctors are thinking that, yes, this is something that needs to be addressed, and that every person is different who's coming through anybody's system or looking for any type of treatment services. So as we begin to take the box and open the sides, We need to expand taking those sides away and look at all the options that are out there and available to help our clients become more successful in their recovery efforts.